Morning, good afternoon, good evening. It's my pleasure to chair this joint webinar session, joined together HTAi and the International Federation of Biomedical Engineering. The topic of our session will be on integration of HTA within the health technology management cycle, and I'll tell you more about the presenters. I am Dr. Yanni Müller and current board member of HTA International, and I also chaired the Scientific Development and Capacity Building Committee. So if you're wondering what is HTAi, as you can see, it's a global nonprofit scientific and professional society providing us with an open platform, allowing global collaboration and also leveraging on the collective intelligence that's out there to, of course, at the end of the day, improve health outcomes. So as I mentioned, I'm chairing the Scientific Development and Capacity Building Committee, and it's as maybe some of you know, it's a a standing committee of the board, as an advisory position, and it guides the scientific direction of the society. Also developing, also when you see the title, developing HTA capacity globally, and also creating learning environment within HTI for its members. And of course, advisory function, its primary responsibility is quality assurance of of all the materials that gets endorsed. I won't go through all the points. This is for you. So if you're interested, please visit our database of educational offers. We provide endorsement of your educational programs, scholarship if you're interested. And that is one of the, evaluation we do, making recommendations to the board and also, providing a monitoring and evaluation mechanism for scientific knowledge and assisting with capacity building. Here in this session, there will be two interest groups and will be represented. The one is on hospital-based HTA, and the other one is on medical devices. I won't tell you, go into details, but it's bringing together healthcare professionals, like-minded healthcare professionals who are interested in what is happening with HTA or what can happen with HTA within the hospitals or when you're applying it to medical devices. So if you're interested, please join, the interest groups. And my last presentation slide is presenting today's speakers. And the next one that I welcome is Murilo Conto, who will talk about the International Federation of Biomedical Engineering and its partnership with HTA International. Thank you.
Hi, Johnny. Can you hear me?
Yes, I can hear you, Murilo.
Thank you. Thank you very much, Johnny. For me, it's a big pleasure to talk in this first webinar, the joint webinar that we are organizing between HTA International and IFMBE. I would like to tell some words about the IFMBE. IFMBE, the International Federation for Medical and Biological Engineering, is an entity with more than 60 years, and we are organizing, joining more than 120,000 members between the biomedical engineering community around the world, with different 60 countries. And we have 3 main divisions in the federation. One of them is the HTA division that I have the pleasure to share in this moment. And we have some goals about HTA, specifically to improve the mechanisms, the methods, how to apply the HTA methods of medical device, because we know the difference between medicines, drugs, and medical device. So I'd like to say thank you for HTA for the partnership, and thank you for the audience. This is our first of, I think, a lot of webinars, the other kinds of jobs that we can organize and we can work together. Thank you very much, Jenny.
Thank you, Murilo. Please welcome Rosella. Thanks.
I share my slides, just a moment. I hope you can see them in presentation mode. Great. I'm Rosella Di Bidino. I am the co-chair of the interest group on hospital-based HTA, and I'm working at the Gemelli Teaching Hospital in Rome in the HTA unit. As you can guess, my presentation is about hospital-based HTA, which is the current scenario, how HTA at hospital level can replicate the multidisciplinary approach of HTA, and then I'll show you how HTA is not an island in all the HTA ecosystem. Before to move to hospital-based HTA, I want to show you some of the members of our interest group. We are more than 260 members. The group is co-chaired by me and the colleague Iga Lipska from Poland, and we can count on the valuable support of the technical officer, Monica Kukra, and of our steering committee. The steering committee is composed by 5 members coming from Italy, Spain, Denmark, and Switzerland. But not worry, our interest group is dedicated time and energy also to investigate how hospital-based HTA can play a role, for instance, in India. We have a project on that. Then let's move to hospital-based HTA. As you can guess from the name, it is an additional level of assessment, additional compare from the European one, the national one, and the regional one. Its aim is to support all the decision-making processes within hospital, both managerial one and clinical one. And as I'll show you soon, the assessment is not limited only to new technologies. In this slide, I give you also a relevant reference, that is the Adopta handbook, that is a very useful tool for assessor at hospital level, and it was produced within an EU-funded project some years ago. Why assessment is necessary at hospital level? Here I try to identify 3 main reasons. The type of decisions that are taken in relation to health technologies at hospital level, the fact that hospital level is more and more a relevant entry point for technologies, and then for the budget constraint that a hospital is facing every day. Starting from the type of decisions, the PICO at hospital level could be different compared, for instance, the PICO at the national level. Let's consider just the case of comparator. When we conduct an assessment at hospital level, we are not interested to compare, for instance, a new technologies with all the other similar technologies that are available on the market. We are more interested in comparing that technology with the other that are already used within the hospital. That's in order to provide the best care and the best personalized care as possible. And we can support both investment and disinvestment decision at hospital level. Then I mentioned that the hospital are relevant entry point. That means that we have to help the hospital to give a priority to the investments in different technologies, and we have also to give a priority to our assessments. And then the issues of budget constraint that is strictly linked also to what is the hospital strategy. Here I reported also 2 additional Elements to consider that are the data sources and stakeholders. At hospital, we are more closely in contact with stakeholders as clinicians, managers, and patients. And then for our assessment, it's really important to consider the real-world data that is collected daily within the hospital. Now let's see what is hospital-based nowadays at a global level. I want to share with you the result of an international survey that we conducted last year, and it was open both to hospital where HTA is performed, hospital where it isn't performed, and to policymakers. Let's focus on the 41 hospitals where HTA is performed. It emerged that HTA is usually performed in big hospitals with at least 500 beds. And almost half of the HTA unit were established in the last decade. Just one was established after the pandemic. The activities of these units is to support both clinical practice and decision-making processes. From an organizational point of view, the units are classified as integrated essential unit. That means that there is a dedicated unit within the hospital, but that unit involves just a limited number of permanent staff, but the unit is also able to involve, when necessary, the internal and external experts. What are the technologies that are assessed at hospital level? They can be all kinds of technologies, as you can see from these slides. The technologies that are more often evaluated are medical equipment and medical devices. But for instance, already in almost 40% of hospitals are assessed digital health intervention. Then what about multidisciplinary? I want to show you the multidisciplinary both in relation to the framework that we use at hospital level to assess technologies and both from the human side, as I'll show you in the next slide. The reference framework for hospital-based HTA is the ADOPTA core model. Here you can see all the domains that are involved by this ad hoc framework. In some cases, the ADOPTA model is adapted to the peculiarity of the hospital or to the specific kind of technology that is under assessment. Anyway, in all cases at hospital level, we assess the clinical effectiveness, and in almost all cases, we assess safety. But as you can see, it's more important for the hospital to assess the organizational impact. And in 33% of the cases, we assess also how the technology integrates with the hospital strategy. So the message of this slide is that at hospital, we can assess all the HTA domains, and for us, it's most important the organizational one. Then, from the human side, the HTA are integrated essential units that employ in medium 3 permanent staff members with different competencies. In almost all the units that replied to our survey are involved clinicians, health economists, and pharmacists. But in few cases are also involved experts in ethical analysis and patient representatives. Then the ADOPTA project identify all the decision-making steps in the hospital. They range from the evaluation of clinical needs to the procurement procedure till the disinvestment decisions. Here you see how many HTA units are involved in each step of the decision-making process. Potentially, HTA can contribute to all the steps, but is not always that the case. The HTA unit are often involved in the assessment of clinical need and the identification of the most appropriate setting of adoption of the technologies. In less cases, but in a good percentage, HTA unit are involved in at least one of the steps of the procurement procedures, and the HTA unit are already involved in the disinvestment decision steps. Then, when assessment is introduced, for sure, it is new technologies are assessed at hospital level. In some cases, are conducted also yearly HTA, and in 47% of the cases, reassessment are sometimes conducted. Anyway, it's not common to have an internal hospital procedure that define the criteria that help to decide when to conduct an yearly or a reassessment. It's just a decision that is taken case by case in relation to the specific technologies and the requirements of the CEO. Then, hospital-based HTA is not an island. First of all, it should have an impact on the hospital decision. I give you the freedom to interpret this slide as you want. I interpret it in an optimistic way because at least in 45% of the cases, our work have a medium impact on the decision. And in 33% of the cases, it has a high impact. So, which is the perception of hospital-based HTA? Is it perceived as duplication of work? Here you can see the responses provided by hospitals where HTA is performed and hospitals where HTA is not performed. Luckily for us, HTA is not perceived as a duplication of work in the majority of the cases, even if in hospital where HTA is not performed, HTA is perceived at least as the partial duplication of work in the 38% of cases. Then, what about the external ecosystem? All this HTA unit operates in countries where there is an HTA national policy, but there isn't a policy or regulation dedicated to HTA at hospital level. Despite that, HTA unit have a good level of experience in collaborating with national agency or academia. Here on your right, you can see some examples taken from my hospital, the Gemelli Teaching Hospital. We are a partner in a European project as HTA, whose aim is to develop a framework, an HTA framework for all kinds of digital technologies. Then we are a collaborative center of the Italian National HTA Agency, and we have a quite strong experience in the collection and in the analysis of our real-world data. We have a unit also dedicated to the use of real-world data to develop AI algorithms. So, I already show you some barriers that HTA face, that are the lack of formal recognition and the limitation in human resources available. But thanks to a study that as interest group we conducted last year in 7 countries, we are able also to identify some facilitators, external and internal. A facilitator is the creation of a network of hospitals performing HTA, and I hope that the interest group can be this kind of network. One facilitator is to dedicate more time to the dissemination of our work and to the communication of our own work in a better way with the manager, top managers of hospitals. And then next, we have to stress the training of people in HTA and in hospital-based HTA. So in conclusion, HTA can play a crucial role in hospitals. It can contribute to the different steps of the decision-making processes, as I showed you. It can also be an active actor in an overall HTA ecosystem. HTA unit has already some kind of expertise at this level. We have to work more on collaboration and dissemination of our work. Thank you very much for your attention.
Thank you for Rosella for introducing us to the hospital-based HTA and how does it look globally and what are the benefits and challenges facing those trying to integrate HTA into the hospital decision making. Thank you. And now I call Toby to present, please.
Thank you. It's really a pleasure to be here at the joint session between HTAi and IFMBE HTAD. And especially want to thank the IMF group for the IFMBE group for inviting me to present here. So let's start off here with the first slide. I hope everyone can see my screen and you can hear me okay. So today I'm going to talk about medical device and equipment factors in HTA. My background is primarily at University of Vermont, where I'm the director of their collaborating center with WHO for HTM. Also work with PAHO and RIDETSA, which is the group in the Americas, which focuses on HTA, and teach part-time. However, I'm not representing WHO or PAHO or RIDETSA in this presentation. I just want to make that clear. So starting off, just want to look at some definitions in terms of medical devices and its subset of medical equipment. So WHO definition here is shown that it's really a medical device has a broad range: article, instrument, apparatus, or machine used prevention, diagnosis, or treatment of illness, etc. So that's a somewhat broad definition. It's not as broad as our FDA definition of medical devices, which is much more wordy. Also, the WHO, and there's a link here to these definitions, has a definition of medical equipment. The differences you can see: calibration, maintenance, repair, user, and I inserted technical staff training. For the purpose of this discussion, I'm going to be talking about the medical equipment that has a power source, and of course decommissioning or disinvestment, as you may describe it. So I wanted to look at what the factors showing assessment differences between medical devices and medical equipment, and try to kind of hone in on some of the key differences here. And looking at the factors, we have interdependence of technologies. This would be interaction between medical devices and other systems, or medical equipment and other systems. I'll give an example of medical device interaction between medical devices, which is kind of interesting in the next slide. But certainly medical equipment has many interactions with other medical equipment, with networks, and for complex systems, telecommunications, etc. In terms of the application, diagnostic or therapeutic, I think medical devices has more of a mix of diagnostic and therapeutic applications, whereas medical equipment, the majority is diagnostic, which makes it harder to evaluate in terms of HTA as opposed to therapeutic. Does it cure the disease or not? Training, medical devices requires training. There's instructions for use for even the simplest medical devices. This training could be for the clinical staff, it could be even for the patient who may be utilizing a medical device. Medical equipment, the training requirements are much more comprehensive, and they encompass not only the clinical staff, but also technical maintenance staff and others, maybe IT, and the patient, if the patient is the one utilizing the technology. Usability, which is basically how easy it is to use. You know, the initial clinical application would be evaluated, sometimes ongoing, and the same goes with the medical equipment. Maintenance, none or minimal for medical devices, but certainly very significant for some complex technologies. Life cycle, it depends on the medical equipment item, whether it's a disposable or an implantable, broad range there. And for medical equipment, you might look at between 3 and 25 years. Safety, I think, you know, the medical devices certainly have initial evaluation for safety. And following that, at least in the US, with our medical device reporting system, it seems passive in that there are reports that are sent in after the fact if there's an incident. Whereas for medical equipment, there's more of an ongoing quality assurance process. So just a quick example here of a medical device that has independency of technologies, medical body networks. This is a IEEE standard adopted by many regulators for a connection between various medical devices in or attached to the body. So this is an interesting example and becoming more and more common. Of course, there's other connections that may take place with medical devices. At the University of Vermont, our technical services partnership, which is a clinical engineering, healthcare technology management organization where our collaborating center is located, we developed this kind of diagram to show the healthcare technology planning and management cycles, as we call them, where you, of course, you have your assessment starting point. At the same time, there's going to be a replacement of technologies, which would be perhaps called disinvestment or decommissioning of technologies for, say, clinical reasons. However, there are technical reasons to replace the technology, whether unresolved safety problems or no longer support for the technology. Budgeting is next, combining the new assessed technologies and the replacement technologies, and then acquisition. This is all fed by data collection and analysis, the literature, marketing, etc. Then the technology is deployed, and then we get to the actual management part of the technology where it's being utilized. Certainly education and training, installation, etc. Takes place. Safety, monitoring, as I mentioned, the quality assurance and safety, and maintenance. And in the US, we have quite a lot of compliance requirements. The data collection analysis here is a computerized medical equipment management system that tracks everything from mean time between failure to any safety issues, and that data is fed back into the planning. So in looking at the 4 key areas for assessment, need, benefit, cost, and impact, not too much difference between other technologies and medical equipment or medical devices in terms of need. There either is the need or not. In terms of benefit, you know, again, the medical equipment is primarily diagnostic, and the medical devices have a mix. Cost is something to look at closely in terms of your medical equipment. Life cycle costs can be very significant, and we'll get into that a little bit more. I think one of the biggest areas for medical equipment that affects the healthcare technology assessment process is the impact. With the maintenance, consumables, networking, infrastructure, et cetera, requirements, it can be significant. So here's another example of interdependence of technologies. For this, Rosanna Rivas and myself taught a class in Guayaquil, Ecuador at ESPO. And we visited the hospital here showing the PET CT scanner and the cyclotron that are at one of the hospitals there. So this is just probably a overemphasized example of technology, but there's many network connections, ancillary equipment. You have room control for temperature, humidity. You have plumbing, electrical, telecommunications, radiation shielding. As many aspects of technologies are applied here for this example. Looking at diagnostic again, stating that the majority of medical equipment is diagnostic, and certainly the more complex ones outside of, say, linear accelerators and some other robotic surgery are primarily diagnostic. And we have a new example here, the OptiSite. Other unique aspects. Well, again, training is very important. Your clinical staff obviously needs to be trained, sometimes certified. Technical staff from IT needs to know how to connect equipment to the network. Maintenance staff, and that's both initial and ongoing training, and patients. Usability is critical because use error seems to be the primary cause of adverse events. And if the device isn't correctly human engineered and the human factors design isn't appropriate, you're going to have those adverse events occurring. Maintenance, this is a long list here, including a number of things: installation, acceptance testing. Disinfection is one thing that's not always considered. Disinfection, it takes time, whether it's with a robot or whether it's with the housekeeping staff. And also disinfection causes equipment damage over time. Preventive, corrective maintenance, software upgrades, and deinstallation. So there's a couple of references here that I thought was interesting. One, provides the typical, in the US anyways, 10% of the purchase price is annually spent on a service contract. This can go up as the equipment ages to a higher percentage. Interestingly, I think this started back in the 1980s. We had developed something called maintenance insurance because the actuarial data said that service contracts really cost 100% more than the actual service that was rendered. And there's even more interesting for Patrick Lynch, examining cost of service ratios, if you wanted to look at that. Life cycle. So as I mentioned, medical devices, everything from single use to implantables. Medical equipment, just as somewhat of a guideline, portable ultrasound, 3 years. Sterilization equipment can be 20, 25 years. And of course, I'd like to include this diagram from David Banta, who's in the U.S. Certainly best known HTA individuals as part of our former government's Office of Technology Assessment. We don't have a continued Office of Technology Assessment. We have FDA activities. We have Centers for Medicare and Medicaid Services that does some technology assessment, but certainly not what you would call a national program. So the last slide here I wanted to cover briefly was final note on medical equipment total cost of ownership and the iceberg. So you can see the acquisition costs really have to be looked at as just the tip of the iceberg. Purchase price, shipping, installation. Okay, now it's ready to be utilized in the system. Staffing and training. So staffing is difficult to find, and you have to train them. If they leave, you have to train somebody else, retrain them. Maintenance, again, 10% or higher. For service contracts, could be much lower if you provide a self-insurance program. Consumables are utilized, utilities, disinfection, upgrades. A new thing is software licenses, where you have to get licenses for, say, individual beds in an ICU. Financing, compliance, quality assurance, and deinstallation and disposal. You know, units such as cobalt units that have to be deinstalled are very, very expensive and difficult processes, and all types of fixed equipment can cause problems. So with that, just want to thank you for having me here for the presentation, and my email is there.
Thank you, Toby, for sharing, the differences, or, what is particular about assessment of medical devices and equipment, and differentiating it, and the need for, certain aspects and factors that goes with devices and equipment that we may tend to overlook. Thank you. I welcome Richard.
Thank you. I'm just pulling up my screen. Hopefully you'll see it soon. Hopefully it's the right screen. Okay, let me know when you see it. Yanni, do you see that now?
Yes, it works. Thanks.
Wonderful.
But, yeah.
So thank you, everyone. And by the way, I just want to mention that Toby's talk, that actually, the last slide there looks shockingly like the value-based procurement framework that we have here in Europe. So it's quite similar. That's always encouraging when we see similarities between what we see here in Europe and in the US. So thank you for sharing that slide. I'm going to talk a little bit today about a case study on robotic surgery, and then also set the foundation on the alignment between the medical device interest group at HTAi, but then also the IFMBE, and how we interact and can move forward on the topic of integrating HTA within the health technology management cycle. My name is Richard Charter. I'm the founding and managing director of Chloe Healthcare Advisory Group Limited. Chloe is the name of my daughter, but it also stands for Consortium in Healthcare, Leveraging Outcomes and Expenditures. So feel free to reach out to me afterwards if you have any questions. In the interest of time, to make sure we have time for questions, I'm going to have to go relatively quick. So feel free to either put them into the chat or reach out to me directly afterwards, okay? So let's go through very quickly why this collaboration is important. And I just want to set the stage with what I consider to be my initial slide for almost any presentation that I give. So apologies to those that have seen this before. But healthcare is very unique. It's the only industry on the planet that has got a separation between patients, physicians, and payers. So those benefiting, those paying, and those recommending the technology are discretely different. And that has got big ramifications for value articulation and also what it means for HTA. And that's confounded by what I consider to be the three public health challenges, which are providing high quality healthcare that balances patient population and now planetary health outcomes. The second one being paying and administering for healthcare despite very limited budgets and rapidly growing demand. And then third, of course, ensuring equality of care that minimizes social determinants of health and provides universal healthcare coverage. Recognizing that universal healthcare coverage is not something you find in the US, it certainly is here in Europe, and also where I'm from in Canada as well. So those three goals represent somewhat of a challenge for both HTA and policymakers overall. And I think the solution to that is relatively simple, and we see this through HTA as well, but really it is how you define value, whether it be this conventional value-based healthcare definition or more of an HTA definition. They're essentially the same, and that is some form of ratio between the health outcomes achieved from a technology versus the total cost of delivering that outcome. And that total cost, which is why that final slide from our prior speaker was so important, because there's a lot more that goes into a cost of a technology, whether it be a medical device, a diagnostic, digital health, medical equipment, than what the upfront expenditure really is. And what's also interesting is if we go back to the first point, that has to be split over multiple different stakeholders. So from the IFMBE perspective, how is what you're doing relevant to physicians, providers, payers, procurement teams, policymakers, and patients? And by considering all of these variables, the organizations that do that the best are the most successful, whether it be on the private manufacturer side or from the government stakeholder side. So I also went to the IFMBE website because I think this is really important as well. And the goals of the IFMBE, and these are copy pasted from the website, you can see here. But the two that are critical are number 2 and number 4. And both of these are really designed in some way to foster the creation, dissemination, application of medical and biological engineering knowledge across the product life cycle, but also to advance collaboration between national and transnational societies. And that dovetails very nicely into HTAi's overall mission, which Debyani went into earlier in this call, but also to the HTAi Medical Device Interest Group mission, which is to promote the role of medtech in interdisciplinary and multi-stakeholder health technology assessments to enable the holistic shift of healthcare systems towards the key principles of value-based healthcare, which are improving outcomes and lowering total system costs. And our 3 goals really are to produce relevant, objective research to inform and improve policy making that is intended to improve population health. It's also to advance the dialogue on medical device HTA methods and evidence-based policymaking. And then finally, to reflect all stakeholder groups and ensure the unique role of HTA is considered in policy discussion. And again, that all stakeholder thing is one of the critical differentiators that we like to emphasize. The Medical Device Interest Group itself is chaired by both myself and Anastasia Halkidu from NICE, which is one of the larger, more reputable HTA organizations globally, and then all backed up by our technical officer, Jarno Suominen, who also works at Terveystalo. So big thanks to the other group leadership. So again, in the interest of time, I'm going to fly through this part, but a detailed understanding really is needed of medtech. And I want to kick it off by having an overview on the regulation changes that are coming down for medical devices and diagnostics. First one, which I'll talk about a little bit here, is the IVD and MDR regulations. Second one is the EU HTA regulation. That is a whole other topic, which I will not have time to talk about here, but it's something worth considering. As I mentioned earlier, through the value framework that came from the EU Most Economically Advantageous Procurement Directive, that's also leading to a significant shift in things. The EU Green Deal, which is leading to environmental sustainability. And then certainly with respect to patient data, GDPR regulations. All of these and others, I should say, are materially impacting how medical devices are brought to market and why evidence across the product lifecycle is so important. In short, the impact of the MDR and IVDR, and this is just one of the regulations, as you can see above of the 5, is point 3 there. It's really calling for stricter requirements for clinical evidence and post-market surveillance. Post-market surveillance means everything after CE mark, which is something that many smaller or startup medtech or medical equipment companies often don't consider. They just think that the CE mark really is that terminal endpoint, when in fact reimbursement, pricing, and HTA really needs to be brought in, especially in the context of this new MDR. And this life cycle curve, similar again to what the prior speaker showed, really starts to highlight things. So we move from the product design and development phase through to product diffusion and adoption, then over to product maturity and iteration phase. And the idea here is you need to minimize that time to revenue for the medtech companies specifically between product launch and CE mark, but between reimbursement and HTA evaluation. However, that's not always as easy as it seems, because when we get into the next slide, one of the nuances of the medtech space is that the user learning curve and the time taken to learn something after CE marking can materially impact the patient outcomes and therefore the value associated with the technology. So having it too soon actually leads to lower value and lower perceived value on the technology itself. Leaving it too late leads to problems. And again, I'll speak about this in just a moment. But the idea is it leads to the discussion on how evidence for medtech should be produced. And I'm a relatively strong believer, certainly for class 3 high-risk devices, the randomized controlled trials, they've certainly got a place. They need to be done in order to improve that safety and efficacy within a controlled trial environment. But there's also the place for observational studies and real-world evidence, certainly when linked into post-market clinical follow-up evaluations, which again are something that medical device criteria are requiring. But the key point here is that if you look at the entire product life cycle, it's minimizing things between product launch and between reimbursement and HTA evaluation. And the more effectively innovation can get into the system, the more effective patient outcomes can be improved. Now, the key takeaways here from the medtech perspective are that companies have to focus on funding and not CE mark as the final end goal. You're just leaving too much unknown to not have a consideration for later stage value than if you only focus on the CE mark. Number 2, this focus must be across the entire product lifecycle. And then number 3, minimizing the time to product funding and adoption really is essential. Now, one of the key differences between the evidence required for regulatory purposes is basically the following. Is the product safe and is the product effective to get CE mark? All that really indicates is that in a vacuum, in isolation of any comparator or any existing products, they just want to, the regulators really just want to know, is the product safe and is it effective? Is it going to do what it says it's going to do? And is it going to harm patients? If not, essentially, under obviously all the requirements, then your CE mark will be granted. But evidence generation for reimbursement in HTA really goes much deeper. It really wants to know what the incremental value is over the existing standard of care or over the existing comparator technologies. And you can see some of the questions that evidence generation for reimbursement starts to factor in. But that leads to this risk dynamic that we see come into the equation. And again, I won't go into much detail on this. I could spend an entire session just on this one slide, but the uncertainty of revenues from medtech are the almost diametrically opposite to the uncertainty of payer expenses. So there has to be some balance and mitigation of these risks. And without this evidence to substantiate that, this different distance just becomes more and more. Therefore, the key industry for risk is the uncertainty and timing of revenue. For payers, the risk is uncertainty of cost and value for money. And for providers, the risk is patient and population outcomes. And then again, in some cases, it's also the value for money as well, depending on the nuance of the provider we're looking at. But the critical differentiating areas for medtech really come down to the following 6 buckets. Now, again, apologies, but in the interest of time, I'm going to go really quick here. If we look at number 3, the user learning curve, the user has to learn how to use a device, and increased usage can lead to improved outcomes. And that is a critical variable that determines when and how evidence is produced for medtech. So through the medical device interest group, we went through a case study in robotic surgery, okay? And this was a really interesting topic because really what we aimed to do was understand how the rapid evolution and spread of digital health technologies challenged existing HTA frameworks. And we can see that some of the areas like rapid pace of technology innovation, increasing demand and pressure to evolve HTA methodologies, in some cases, inadequacy of some HTA methodologies for medical technology solutions, as well as the siloed efforts of some staff. Again, if we go back to Rosella's presentation, we saw all the different stakeholders that were contributing to hospital-based HTA. There's a lot of disagreement amongst those stakeholders, so we aim to address some of these issues. So we aim to develop a guideline for the best practices of HTA specifically for robotic surgery. And the way we did this was we came up with 12 to 15 experts under the guidance of the medical device interest group to look at how to create a consensus document. And we compiled it of multiple different stakeholders, so clinicians, economists, policymakers, payers, and so on and so forth. And then we essentially had a study steering committee to undertake the background research to facilitate the panel discussions and draft up a manuscript for publication. But what's really interesting in the backup research is that we found about 98 HTA reports done on robotic surgery. And I have this split out by therapeutic indication as well, but I'll save that for another time. But more importantly, we can see the increase on HTAs done over time on robotic surgery. Now, when you think about this in relation to your technology, whether it be robotic surgery or not, if the number of HTAs is increasing, you're going to have to pay attention to what those HTAs are saying. And that led to some very interesting results for robotic surgery specifically. We saw a range on ICERs, everything from 14,000 incremental cost per quality gained in British Columbia to, in some cases, in Ontario in 2020, where we saw it below 2,000. That's the same country, I'm from Ontario in Canada myself. That's a very promising ICER for robotic surgery platforms in Ontario, but it looks very expensive in British Columbia. And that really raises the question, why? And if they're the same platform in relatively similar healthcare ecosystems, it really indicates that the methodology is quite mixed. And therefore, understanding how the methodology for HTA across your product lifecycle can become absolutely critical. The first thing is we noticed that the time horizon varied significantly. So it ranged from 1 year in Ontario to 10 years with the Paccarel study in 2020. Just the time horizon alone means that there's vastly different time perspectives on the information itself. The discount rate used, 5% in Ontario versus 1.5%, again, for the Paccarel study, which, again, really is a large difference when we're looking at the timeframes that we're looking at. The service lifespan of the system, 9 years and 10 years, so that was approximately the same. And then also things like annual procedure volumes, 200 versus 400. Again, when we think about the user learning curve, in the first instance, there's 200 examples where that gets fed into what the patient outcomes were, where in the latter, we're up to 400. if we move forward onto things like the ICER base case, we see that the Health Quality Ontario really came in at a 5.2 million cost per quality versus 25,000 of the cost per quality for the Paccarel study. Again, such widely differing cost per qualities, it really needs some methodology outcomes to be achieved. So therefore, through the 14 individuals that we had in the interest group, we actually published a paper in one of the recent International Journal of Health Technology Assessment, and it was entitled Best Practice Considerations on the Assessment of Robotic-Assisted Surgical Systems Results from an International Expert Panel. And we came up with the following 7 consensus statements. And again, I'm not going to go through all these in the interest of time. I want to make sure we got a couple of minutes for questions. But first off, things like given the complexity in assessing the clinical effectiveness of robotic ecosystems in practice, real-world evidence should be considered for the inclusion in health technology assessment. Another important one, as I highlighted earlier, number 5, the time horizon when building a value framework for robotic platform should consider the clinical outcome and level of decision maker. So is it national or is it local? And again, those will be somewhat different. And then multi-procedure cost analysis will more accurately affect the cost effectiveness model of a robotic system in practice, and therefore methodological work is needed to develop these multi-procedure approaches. And then last but not least, the value of the entire robotic ecosystem really should be considered by HTAs conducted on the robotic assisted surgery. So again, the idea here is that when HTAs are being conducted, are they really fit for purpose for the specific medical technology you're looking at? And the medical device interest group really delved into this. So the key conclusions and takeaway for this from this session, number 1, rapidly evolving medical technologies will require differing HTA methods across the product life cycle. So when you're looking at your technologies, make sure that you understand what those are, how they're being evaluated, so you can see how your technology will fit in specifically. Number 2, digitally enabled technologies will require evidence generation that aligns with new regulations, specifically the medical device regulation and IVDR and the HTAR as well. And then last but not least, full consideration of product lifecycle and evidence dynamics should be at the heart of any product adoption and commercialization strategies for products, procedures, or any, for example, AI algorithms. So with that, I'll say thank you. I went through that much faster than I intended to, but I do want to make sure we got some time for questions. So Devyani, I can turn it back to you now. Okay.
Thank you, Richard. Yeah, that was a lot to cover, right? You could have spoken a few more minutes, 10, 20. And yes, that's a lot of information that we also need to know. So before I hand over to Rosanna, I would welcome your questions. Please put them in the Q&A, and it will take a few minutes only to answer those, or we can get back to you later on.
It was an amazing session. I am sure that all the attendees connected have enjoyed a lot the contents. My name is Rosanna Rivas. I'm co-chair of IFMBE, Health Technology Assessment Division. And of course, I'm very honored and proud about the contents that our distinctive colleagues have provided today. HTA integration with health technology management approach was presented from the approach of a hospital, the medical equipment value, and also the regulation and his impact in the impact in healthcare systems. So I'm sure we have a few time, Johnny, but some relevant moment for the questions and answers. So let's see in the chat. There's no question yet in the chat. I wonder if you have a question, Johnny. I have one.
Please go ahead, and then I'll propose mine.
Okay, so it is open. We are convinced globally that this health technology assessment is a topic not just pertinent, but gradually more and more needed. In your opinion, and regarding your respective approaches, I would like to know what is your insights about the obstacles to make it happen in each context. I believe globally there are differences between the contexts, but why, in your opinion, is the main obstacle is the question. Thank you for the implementation.
Maybe I can jump in on that, Rosanna. I think one of the biggest obstacles is resourcing, to be honest. I think it's resourcing, and then as I alluded to, the multi-stakeholder perspectives on value. We certainly see this, and I had a conversation with my co-chair from NICE, and it's, for example, in the medical technology space, it's often believed that the biggest barrier is that not enough HTAs are done, and they certainly don't come with a funding mandate. That's actually not necessarily true. What is true is that how do you get all these different medical technologies into clinical adoption, right? You see healthcare systems that are stretched. We've got staffing that is, pushed beyond the barriers of what they can currently do. So when you start introducing new technologies, new pilot programs, new ideas and new concepts, new workflows, that's adding to their workload. And I think that's arguably one of the biggest challenges, but that also highlights how important this is, right? Like, I believe that the economics of healthcare are actually one of the biggest public health risks, is if we don't allocate health effectively, that actually leads to downstream consequences of, what care patients get. So I think it's multifactorial, but I honestly believe it comes down to resourcing.
Thank you.
If I made something, I fully agree with Richard that is a problem of resources, human and economical one. It is, at least from the hospital perspective, also a matter of timing. Sometimes we at hospital level, we have to assess technology before the HTA agency.
Right.
So
exactly.
Any hospital duplicates the same assessment, given that we don't have already so much effective network or time, we don't have time to disseminate all our assessments.
Nice. Thank you, Rosella. Thank you, Richard. Toby?
Well, the U.S. perspective, of course, is different in that we don't really have kind of the HTA national organizations, if you wish. Working with other countries, primarily in the Caribbean, you see that the resources are very limited. The knowledge is limited. If you wanted to develop something sophisticated, such as the European model, that's extremely difficult given the personnel and time constraints. It's great that REDETSA exists for the Americas, and I think it is the resources. I would agree with both Richard and Rosella.
Thank you. Gianni, up to
Yes,
you.
yeah, we have one question from the audience, from Yanga, and to Richard. And it says, what similarities or differences have you found in the evaluation of robotic surgery across the different countries, which may explain then the different ICERs? Richard?
Yeah, so again, great question. And I went through my presentation really quickly, but so there, and you can follow with me afterwards directly if you want. I can send you the table, but everything from time horizon to the discount rate used in the economic modeling to the service lifespan of the system, not necessarily the lifespan of the system itself, but how that lifespan was accounted for in the economic evaluation. The number of procedure volumes annually. So some have got double what others were doing, which leads to the inputs creating a different output on the HTA itself. And then even things like expected cost over time, right? So, and how that's calculated. It's really, in some cases, and that's why I highlight the case of British Columbia versus Ontario from my home country in Canada. It's because you got two relatively similar, no two are alike, but you got two relatively similar healthcare systems in British Columbia and Ontario. You got the same platform. Therefore, the only variance there for producing an ICER really would be the methodological inputs. So, and that's that slide that I pulled up, but feel free to reach out to me afterwards and I can send that over to you. Okay. It's also actually in the publication, which you can QR code as well. Okay.
Thank you. Thank you, Richard. We are 2 minutes over the hour. And this is the end to our session. Actually, I'm looking forward to, further collaborations and further webinars and workshops on this topic. So thank you all for joining us. And thank you to Murillo and Rosanna, and to Rosella, Toby and Richard for your excellent presentation. And and also the possibility, opening the possibility for in-depth discussions later.
Thanks, everyone.
Thanks.
Thank you.
Thank you.
Bye.